In today's session, we will discuss about the Coccyx AP view. The Coccyx anterior-posterior AP view is used to demonstrate the Coccyx in conjunction with the sacrum and Coccyx lateral view. Follow departmental protocol in relation to imaging the region. Okay, so Coccyx AP view is used to demonstrate the Coccyx. Fine. Okay, Coccyx vertically indications. This projection helps to visualize pathology of the Coccyx, especially fractures, to minimize superimposition of structures over the Coccyx region. The urinary bladder and large colon should ideally be emptied before this examination. Before this examination, large colon should be empatized, or through this view you can evaluate the pathology of Coccyx, or especially in fracture. The management of coccygeal fracture is nearly always non-operative. Some radiology suggests that X-ray evaluating coccygodynia is a waste of resources and exposes patient to unnecessary identification. Okay. So the patient position. The patient is supine with arm placed comfortably by their side, leg extended. Like supine AP position, patient is aligned, or patient asked patient to lie in supine AP position. Technical factors. This is AP view. Centering point, centering point or central ray should pass through the 5 cm superior to the pubic symphysis at the MSC mid-sagittal plane. Central ray angled 0 degree, 10 degree caudal means toward feet. Collimation must adhere to the Alara principle, means it follows the Alara principle given the radiosensitive region exposed by the primary beam. Because the beam should be collimated for Alara principle application, and to say or to protect the region that is very much sensitive to present nearby the Coccyx region. Close collimation to the area of interest. Orientation should be portrait. Detector size 10 by 12 inches. Exposure factor, the KVP is in the range of 70 to 80 MAS, should be the 12 to 16 to 30 MA. Okay. FID, source to image resistance, should be 100 centimeters. Grid is used due to higher exposure factor used. Image technical evaluation or radiographic appearance. Adequate penetration should clearly demonstrate the Coccyx region. The Coccyx is free of superimposition from the pubic rami. The lateral margin of the Coccyx is equidistant from the pelvic rim, indicating the no patient rotation. Practical points: given the proximity of this anatomy to the gonadal region, the risk versus benefit to ionizing radiation and diagnostic value should be considered before imaging occurs. Okay, because it is present nearby the anatomy of the gonadal region, so the risk versus benefit of ionizing radiation and diagnostic value should be considered before imaging. So the lateral view, Coccyx lateral view is utilized to demonstrate the most distal region of the spine in the lateral position. The Indications for Coccyx lateral view. This projection is commonly used in conjunction with the AP projection and can be used as a sole projection depending on the departmental protocol. It helps to visualize pathology of the sacrum and coccyx and investigate the cause of sacral and coccyx pain in both acute and chronic conditions. So it is used to visualize the pathology in the coccyx or sacral region when the patient is come with acute or chronic condition or pain. Okay, in the department. Patient position. The patient is in the lateral recumbent position. The patient can be either on the left or a right recumbent position depending on which is more comfortable for the patient. Flex the knees. A cushion under the waist can aid patient comfort. It is for the patient comfortable or comfort. Ensure the patient is in true lateral position. The next is technical factors. Technical factors. It is the lateral view centering point 8 to 10 centimeter posterior to the ASIS. Anterior superior iliac spine. Okay. Central rays angle perpendicular to the IR image receptor 90 degree. Central rays should pass through the 90 degree of the image receptor. Collimations superior to include the L5 S1 articulation, inferior to include the distal coccyx, anterior to include the entire anterior margin of the sacrum, posterior to the skin margin. Orientation should be portrait. Detector size 10 by 12 inches. Exposure factor is in the range 70 to 80 kVp and the MAS 30 to 40 mAs. SIG shows to image receptor distance is 100 as like AP view. Grid is used. Image technical evaluation. The entire sacrum and coccyx should be visible from L5 S1 to terminal coccyx. No patient rotation as demonstrated by superimposition of the greater sciatic nose and femoral head. Adequate penetration should clearly demonstrate sacrum and coccyx region. The practical points: placing lead posterior to the sacrum on the imaging table will help to reduce scattering radiation. This projection can be performed individually, although they are most commonly performed in a single image. The sensitivity of a plain radiograph for demonstrating acute injury in the region is relatively low, with conservative treatment occurring in a high proportion of cases. Means the AP and lateral both view is performed for the when patient is come with the symptom of acute and chronic condition or pain in the back region, in the lower back region. Okay. So we can, one can see in this through these images any fracture, any type of pathology. Okay. So thank you. This session is over. Namaste. In today's session, we will discuss about the calcaneum axial and lateral view. Calcaneum axial view in the radiographic technique of whole body BScRT second semester. Let me discuss about the calcaneus or calcaneum axial view. That is a part of a calcaneum series view assessing the talocalcaneal joint. Talo means talus with talus when talus joined with the calcaneum. So talocalcaneal joint and the plantar aspect of the calcaneum. Plantar aspect. Okay. As technically advances, CT has widely been used to better visualization characteristic calcaneum fragment displacement and a fracture line. Indications: why this view is performed. This projection is best used to visualize pathology or a fracture resulting in medial and lateral displacement. It's a diagnostic sensitivity of clinical calcaneum fracture. Okay, or patient position. Patient is supine or seated with the affected limb extended. The posterior aspect of the ankle. Posterior aspect of the ankle is resting on the image receptor. Image receptor or foot is dorsiflexed until the plantar surface is running perpendicular to the image receptor. Okay, dorsiflexion can be aided with a tape or a fabric wrapped around the distal phalanges, to be pulled backward by the patient. This should only be performed if the patient can tolerate it. Okay. Technical factor, exposure factor, it is the planto-dorsal projection centering point. The central is angle of 40 degree cephalus, means toward head, from the long axis of the foot, centered at the base of the third metatarsal. Collimation, lateral to the skin margin, anterior to distal third of the foot, posterior to the skin margin of the calcaneus. Okay, these are the collimation. Orientation should be portrait, detector size 8 by 10 inches, exposure factor 60 to 70 kbp, or MAS is in the range of 6 to 15 or 8 to 15 MAS. SID, so the image separation should be 100 centimeter. Grade no, because the less exposure factor is used in this projection. Image technical evaluation means what we can evaluate, what we can get through image. Entire calcaneus is visible from the posterior tuberosity to the talocalcaneal joint. Okay, subtentaculum tali is evident on the medial aspect of the image. Okay, subtalar joint should be visible on the superior portion of the image. Okay. Practical point, although it is preferred to have the patient's foot in full dorsiflexion, many times this will not be possible due to the pain. So in this scenario, it is just effective to increase the angle to compensate for lack of dorsiflexion. Okay. So next is the calcaneum lateral view. Is a part of the two calcaneus series. The projection is used to assess the calcaneum, talocrural, talonavicular, talocalcaneal joint. As technology advances, CT has widely been used to better visualization. Okay. Indications: this view is able to assess for bony lesions and also helps in determining the extent and alignment of fractures. Patient positioning. The patient is in a lateral recommended position on the table. The lateral aspect of the knee and ankle joint should be in contact with the table, resulting in the tibia lying parallel to the table. The leg can be bent or straight. Foot is in dorsiflexion. Place the opposite leg behind the injured limb to help avoid over rotation. The exposure factor, central ray should pass 2.5 cm inferior to the prominence of the medial valvula of the distal tibia. The collimation, anteriorly from the hind foot to the extent of the skin margin of the most posterior portion of the calcaneum. Okay, superior to the examined talocrural joint, inferior to the skin margin of the plantar aspect of the foot. Okay, so these are the collimations and exposure factors that are used in the calcaneum lateral view of projection. Orientation of the landscape, detector size 8 by 10 inches. Exposure factor should be less, as like ankle lateral 50 to 60 kfp, or MAS is in the range of 4 to 6 MAS. SID, source to image receptor distance, should be in 100 cm grid, because there is less vector used in this view, so the grid is not used. No grid is used. image technical evaluation or radiographic appearance. The calcaneus is in the image with the talo-navicular joint open. The distal fibula is superimposed by the posterior portion of the distal tibia and tarsal sinus should be open. The joint space between the distal tibia and talus is open and uniform. Corrective point: superior inferior malignant superior aspect of the talus is resulting of tibia not lying parallel to the means. In this session we have discussed about the calcaneal, axial or lateral view. Okay, thank you. The session is over. Thank you. Thank you. The session is over. I think you are satisfied with this session. If you have any query, then put it into the comment box. I will resolve it later. Thank you. The session is powered by digital version 2.0. Namaste.